Hi, welcome to CT Guided Biopsy at ctbiopsy.com. And today I thought I would spend about 15 minutes summarizing spine biopsies and the various cases that I have shown or put up over the last year and a half. Now, the standard protocols remain the same: stopping antiplatelets and other blood thinners, INR less than 1.5, platelets greater than 100,000, but this is only in sick patients, and good and thorough counseling. We use intravenous sedation in most situations when it comes to bone biopsies. We may or may not use intravenous contrast, or usually not for bones, and then obviously choose the appropriate needles and guns. Take material for histology and formalin, but in an Indian setting, in most patients where we don't already know the diagnosis, we must take material for microbiology, both for tuberculosis as well as for aerobic cultures. Post-procedure, most patients who've been sedated will stay in the recovery room for a couple of hours, wait till the sedation wears off, and if there's still continuous pain, continue intramuscular or intravenous analgesia, and then once the patient goes home, be in touch with them for at least up to 24 to 48 hours. When we do spine and bone biopsies, we need this 11 gauge diamond tipped bone needle, a mallet to drive the needle in some instances, a 16 or an 18G semi-automated gun that we're going to put through the 11 gauge, and sometimes and very rarely a Jamshidi, especially if the bone is very, very sclerotic. Before I go ahead, don't forget the table of contents that has listed everything that we've done so far. Let's start with the craniovertebral junction, and then we'll move our way down to L5S1. This is a 31-year-old. I presented this case earlier with a lesion here involving the lateral mass of C1 on the right. And the whole thing is planning, isn't it? So when we scanned the patient the first time, we found that the vertebral artery was overlying the lesion. And so the idea was to clear out the vertebral artery. So a little flexion, and you can now see that I have a clear route into the lesion, and that makes life much easier. So you do have to get the patient in and try different positions. And now you can see that inflection where the vertebral artery is no longer here. So then that's the root, and then that was quite easy to do. I straight away put in an 18 gauge. It was quite thin that I didn't have to use 11 gauge. So the 18 gauge, a little rotation, a hammer, and we were in, and the final diagnosis was tuberculosis. So when it comes to C1, C2 or OC1, C2 and cervical spine biopsies, for you can do it in the supine position, in the prone position. Supine for C1, you'd go transoral, anterolateral from C5 to D1, far anterolateral C3 to D1, and posterolateral for C3 to C5. Prone position for all of the posterior element pathologies, whether you go straight in the midline or posterolateral, and once in a while you might have to do decubitus. Now in the subaxial spine, if the disease is in the posterior elements, then the biopsy is simple. So you can see a biopsy of the lamina here, very straightforward, and you could use either direction, the one that I've used here, or going in the opposite direction. Again, a pedicular lesion, and the biopsy is quite straightforward. Transverse process lesion, and the biopsy is straightforward. But you need tips and tricks when the disease involves the vertebral body. So if you look at C3 to C4, and this is a patient we had with a C3 osteolytic lesion, you can see that here on the MR and on the CT, and the question would be which route to take. And all of these could be valid routes depending upon the situation. Here we rotated the head towards the opposite side, and then after giving contrast, found a retrocarotid route straight into the vertebral body, which is very easy to do in the end. And with again an 18 gauge, without the need to use a bone biopsy gun, we got the answer, and this turned out to be a plasmacytoma. A little lower down, you may have to use an anterolateral route. So here we have the C6-7 lesion. Looks like it's an infective spondylitis. And what would the route be? Now, I have used the far anterolateral route at times. You could even do a decubitus here. But the transthyroid seems to be a good route as long as you can go through the middle of the thyroid. If you go too superiorly or inferiorly, there is a chance of damaging um, uh, the thyroid artery, superior or inferior. But through the middle of the gland, there's really no problem. And so here I just used an 18 gauge straight into the disc. Again, didn't have to use a bone biopsy, and that was quite easy to do. And you can see that I've deployed the gun here, and this turned out to be Streptococcus agalactiae. Just a few points, transthyroid is safe. The first reported was in 87 by Susan Kattapuram and Dan Rosenthal. And then there have been a few cases here and there, but no one's actually written a paper on a transthyroid route. So that's just something to remember. In the dorsal spine, again, we have multiple routes. Here is a patient who has a D2 lesion, and you can see it's very active on the PET. In the prone position, this is where I was, and this is where I wanted to go. And I decided to use a costovertebral approach, between the rib and the transverse process. Now, here I did use the 11 gauge because I wasn't sure of the thickness of the bone. Once I was inside the vertebral body, I put in the 18 gauge through the 11 gauge bone biopsy needle and biopsied the lesion, and it turned out to be lymphoma. So in the dorsal spine, again, we have these approaches in the prone position, going transpedicular, pedicular, going costovertebral, transosseous, perivertebral, and then we have the decubitus route as well. Remember, this is all for the body. If you have a posterior element pathology, then you just use whatever route that takes you straight into the spinous process, the lamina, the pedicle, or the transverse process. But this is predominantly for the body because you have to cross from posterior to anterior to do this. So here is a transpedicular biopsy. Here is a perivertebral biopsy. This is actually in the same patient where we wanted to get material. This is transosseous, where I just went through the rib because there was no other way in, and we needed to biopsy the perivertebral soft tissue for tuberculosis. This is costovertebral, similar to the patient I showed. And this is perivertebral, where we've just gone adjacent to the vertebral body. And it's similar in the lumbar spine. This is a 26-year-old L3 lesion. We can see that here very well. And again, that's on the CT. So prone position, transpedicular, again 11 gauge to penetrate the bone with the hammer. And then through the 11 gauge, I put in the 18. These days I've shifted to a 16 so that you can get enough material. And this patient also had perivertebral soft tissue. So we went ahead on the opposite side with an 18 gauge. And you must do that. If you do have a collection as well. And remember, pus trumps tissue. It's good to not only biopsy the bone, but also to biopsy or aspirate the soft tissue. So again, in the lumbar spine, we have a transpedicular route, a perivertebral route, and then you have decubitus route. So here's another patient with metastatic melanoma, and we've used a transpedicular route to get into the vertebral body, 11 gauge to penetrate the bone with a hammer, and then an 18 gauge through it, and you can actually see the melanotic tissue, which is black. Perivertebral can be perifacet. Here we have to be careful about the nerve that's coming out. And so if you can get in without using the 11 gauge, then you can usually bypass the nerve and maybe sometimes even give some local anesthesia here. And then this is just perivertebral. This one actually I curved the needle to go into the body and then aspirated some pus a little more distally. Now this patient had this particular lesion posteriorly in the vertebral body, and I didn't have a way to get in transpedicularly. So then put the patient in the decubitus position. This is one of those very rare ones where we went transpsoas decubitus, entered the lesion, and biopsied it. L5S1 and upper sacrum, we found people, often find these challenging and then they don't do these biopsies, but they're quite straightforward. So this S1, basically, you have to find that little gap between the foramen and the central canal, as we found here. And remember, the sacral bone is usually thin unless there's a lot of reactive sclerosis around the lesion. And we just used an 18 gauge with a little screwing and a little tapping straight into the lesion. And this was a giant cell tumor. And this is a patient who has a prevertebral or a presacral collection. We needed pus because pus trumps tissue. And all I had to do was go transsacral into the lesion, do a biopsy, do an aspirate, and prove it. So L5S1 and upper sacrum, again, you do transpedicular, transalar, or transsacroiliac joint. You have so many options. Now here again, we have an L5S1 infective discitis. You can see the lesions here. And you just have to plan it. So this is past the iliac bone, it's transsacral into this lesion. So you do have to use an 11 gauge with a hammer, penetrate in, and then through it, put in an 18 or a 16 gauge, and then biopsy and aspirate to get as much material as you can. And remember, through the bone, any route is safe. So in a post-op spine, here is a pathology. Again, this was post-op infective discitis, and I've gone transfacet, and that's fine. And once I even went through the SI joint because that was the only way that I could reach this S1 lesion, and that is also fine. So in summary, spine biopsy challenges are almost always related to approach, especially when it comes to vertebral body lesions. You rarely need a Jamshidi when the bone is very sclerotic, but otherwise the 11 gauge diamond tip will penetrate all lesions. You need the help of a mallet or a hammer, and then through that put in a 16 or an 18G. And remember that in countries like India where TB is endemic, you must try and obtain pus or caseous material for optimal microbiology. Thank you so much for listening to me, and have a great week ahead. Take